Okay, Dr. Playforth, I am so happy to have you here on the My Sleeping Baby podcast. So why don't you tell us all a little bit about yourself and what you do?
Well, thank you so much for having me. We've been trying to kind of schedule this now for a few months, and my having the baby derailed it a little bit, but I'm so glad.
That's what babies do. It's okay.
My name is Dr. Playforth. I'm a board certified pediatrician and a mom of now 3 in Northern Virginia. And I have been cultivating kind of a social media platform with the idea of providing some evidence-based, but also nuanced information for parents, because I think a lot of the information that's out there is very black and white. And so I've been writing at the Pediatrician Mom and blogging a little bit and doing things like this.
Amazing. No, and I totally agree that I know as a mom of 3 myself, that when I was a new mom, it was very overwhelming trying to navigate all this information out there that can be contradicting and overwhelming, and you don't know what's good information, what's not so good information. And so having a platform, by someone like you, who's an actual pediatrician and a mom as well, I feel like that just provides moms with such value that they can't get in, just simply Googling and hoping for the best. So it's really, really phenomenal what you provide your people. And so, today I wanted to talk all about reflux, because reflux is one of those really pesky, annoying, but common medical conditions that we see, primarily in infants, that is a very well-known sleep stealer. It can really get in the way of your little one sleeping well. So why don't we, start off by talking about like what reflux is and what it isn't, and how it presents itself and what it can look like. Give us that overview first.
So reflux is essentially what it sounds like. So when we, a lot of women in pregnancy will have it as well. So the stomach acids are kind of coming up through the esophagus, sometimes all the way into the mouth, and they're causing heartburn, they're causing pain. It's something that we see frequently in young babies, probably more babies than we really know. But because the symptoms look so much like other things, like colic, like gas, like just random fussy baby, it can be very hard to distinguish what is in the reflux bucket and what is not. So a lot of things are called reflux when they're not, and a lot of things that are reflux are, a lot of babies who are refluxing are actually not that uncomfortable. But it's basically, what we call gastroesophageal reflux. And I like to think about it in 2 different ways. So gastroesophageal reflux, and then there's gastroesophageal reflux disease. So a lot of babies are refluxing, and that's physiologic, and it's not necessarily a problem. It's the point at which it starts to become a problem that we think about it.
So when you say refluxing, you're referring to like spitting up?
To the acids coming up. They don't necessarily have to come out of the mouth.
Okay.
I mean, in a lot of cases they do, but silent reflux is sort of its own entity where they're not coming all the way out.
Right. Okay. And so then how do we know if this is a problem, or if it just means that we're doing 5 times as much laundry as we normally do? It might be a bit of a problem, but like medically speaking, how do we differentiate between, something that just causes more laundry versus something that, would require some medical attention?
I think that's a really good question, because when I do like to tell parents who think that their babies are refluxing, but when the babies are otherwise thriving, that tends to be more of a laundry problem than a medical problem. But for babies who are failing to gain weight, who are having feeding aversion, who are just extremely uncomfortable with feeding, where you're worried that was going to then lead to a feeding aversion, those are some of the categories where we start to think, okay, maybe this is something where we need to think about what to do. Unfortunately, with reflux, our options are somewhat limited, and a lot of times, what we end up doing is just waiting for the babies to outgrow it. But that's brutal for the parents and for the babies.
Yeah. Right. No, 100%. So I'm curious, if let's say you have a mom or a dad, in your office with a baby who they suspect might have reflux. They're telling you, like Dr. Playforth, my baby, he won't stop crying. He's miserable. He's irritable. He's just not a happy camper. How do you then figure out whether or not it is reflux versus colic versus gas versus something else if you have this little baby that can't talk but is just unhappy, and all of those things can be causing that crying, that irritability?
This is the problem of pediatrics right here in a nutshell, right? I mean, that's almost always the case. Either your babies or your patients cannot talk, or they're teenagers and then sometimes they don't really want to. But yeah, so if I have a patient come in and the parents tell me this, I mean, the most important thing is to take a careful history. And sometimes I find that what's happening is parents feel lost because their pediatricians don't always have time to take that careful history. And I think that means that's when parents start grasping and going to social media or the internet, trying to get the information themselves, which is, I mean, hard, right? Because it's not your job, it's our job. Mm-hmm. But if somebody came in with this problem, I mean, I would want to talk more about exactly when they're fussy, what the birth history looked like. We'd look at charts and see how well they're gaining weight. That doesn't mean I expect them to be 50th percentile or above. They can stay at the 10th or 12th percentile if that's where they are, but how consistently they're gaining weight rather than dropping off their own curves. So we look at growth, we look at milestones. And we look at kind of feeding behaviors too. So if you take a careful history, I mean, with reflux, a lot of times you can kind of tell based on the pattern of the fussiness, whether it's something like reflux or something like colic, where those babies tend to be fussier later in the day.
Right. With the colic versus the feeding. Right. I do find that with my clients that happens to be with my 3 kids, none of them ever had severe reflux, thank God. But I have a lot of clients with babies who have had reflux, because what ends up happening is, they're in survival mode because baby is so unbelievably unhappy. And then when they finally get it under control, they then come to me for sleep help because the reflux has been resolved, but now they have a really crappy sleeper, as a result. So I see lots of babies with reflux, and they almost always tell me that when the reflux isn't in control, they start to see baby fussing a lot while feeding, because I guess it's causing that heartburn-like pain, right?
Exactly.
Right.
Exactly. So, but the thing is, sometimes, they feed okay, and then you see the symptom more as the acids are coming up, which doesn't necessarily have to be right after the feed. Sometimes that can happen even an hour later.
Yes.
And it happens more if you put them down immediately after a feed, which kind of makes sense. If you just think about the physics of it, gravity is going to help keep things down. And so if you have a bottle, I mean, if you just think of like a water bottle, right? If you have a bottle and you do this, things are going to be moving, upwards up to the top of the bottle. Right. Things are going to stay down.
Yeah. Right. No, 100%. That totally makes sense. Versus, you're right. Like a baby that might have colic, they're typically not going to see those symptoms, later on in the day. So, how do you, let's talk about, because I know that there's regular reflux and then there is silent reflux, which I would imagine is even harder to diagnose. So what's the difference between the two?
So with silent reflux, a lot of times we'll see symptoms like back arching, something we call Sanifer sign, where honestly, like they as they reflux, they're almost trying to rear away from the pain. So you see them kind of doing this back arch thing, and it's not necessarily coming out. So it can take a little bit longer to diagnose. Yeah, because you're not having this. This is a spitty baby. But I think the important thing to realize here is there are babies. A lot of babies spit up, and spitting up can be totally normal. There are babies that spit up and maybe have some reflux, but it doesn't necessarily mean it's a problem. So, the parent came in and said, look, my baby's happy, they're feeding, they're, maybe sleeping, maybe not. That's a whole other thing, but they're growing well. And then they just spit up a lot, but the spit up doesn't seem to bother them. We call those babies happy spitters. And that wouldn't be a baby where I would want to change anything. Yeah. But for the babies that are back arching, even if they're not actually spitting up, those might be babies that actually do have some reflux going on. Right.
No, I remember when my oldest was probably 2-3 months old, she was that happy spitter upper that you were talking about, the one that created like 5 times as much laundry as I was used to. And, you know, I'm a first time mom. I don't know any better, obviously. And there was this, we'll call this person a well-intentioned family member who had the best of intentions, who saw my daughter Amuna, you know, spitting up like crazy. And she's going, oh my gosh, that shouldn't be happening. This is not good, guys. You got to take her to the doctor immediately. And I was like, okay, I'm going to go to the doctor immediately because I'm a first time mom and I don't know any better. And so I took her to the doctor. And my pediatrician is wonderful. And, you know, he kind of calms me down and he's, you know, weighs her, sees that she's fine. And he's going, nope, it's really no problem. She's, you know, gaining weight properly. Is she happy? Is she eating? Yes, she's happy. Yes, she's eating. Yes, she has lots of, you know, wet and dirty diapers. Okay. So she spits up a ton, you know, that was it. And so, you know, I managed to, you know, catch my breath immediately because yeah, it's only a problem if it's like an actual problem, you know, and simply spitting up is not a problem unless it comes along with, you're saying either like weight gain issues, feeding issues, like nonstop irritability throughout the day. Right.
Yeah, exactly.
Okay. So if you have, so let's say, so you've decided, okay, I think that this baby, you know, most likely has some form of reflux here. What's the next step when all signs are pointing towards, you know, a reflux diagnosis that is a problem?
So the most important thing is actually what we call kind of environmental precautions. So, you know, as I said, reflux is a normal process, right? It's physiologic. A lot of babies are regurgitating. But if you're getting to the point where now you're starting to see those problems, the very first thing I tell parents is, you know, what are you doing around the feed itself? You know, are you feeding your baby and immediately putting them down, or are you keeping them upright? Some babies don't need to be burped, but I found, I have 3 kids, right? Every single one of them had reflux. And I haven't ever put together a post about reflux because honestly, I think I kind of have some PTSD related to it.
Really?
It's so hard. And the first 2 also did not gain weight. And it was just so hard to like navigate exactly that process and having pressure from family members. Because even when you're a pediatrician, you still get that pressure.
Right. I'm sure.
You know, and trying to figure out like, am I missing something? You know, I would take the kids to my pediatrician and they would say, no, you know, they're not getting weight great, but like things are still basically okay. It's just like run of the mill reflux. And
yes,
you just kind of in the middle of the night when you're awake and you're tired and thinking, that's when, you know, you kind of get into like almost like a fixation. So the first thing I do is take a step back. Let's talk a little bit about exactly what reflux is. Let's talk about reflux being a normal physiologic process. Now, let's talk about what you're doing around feeding. So if you are putting your baby down, what we usually say is try and keep them upright for 20 to 30 minutes after a feed. Mm-hmm. I look into a little bit of, you know, are they breastfeeding? Are they feeding with pumped milk via bottle? What kind of bottles are they using? How well are they burping? My current baby, so he's 3 months old now, he 100% needs a burp halfway through a feed and then at the end of a feed. And if he doesn't have that, I mean, you could just tell he is so uncomfortable. Yeah. Frequently as he burps, some spit up will come up with it, which makes sense. You know, again, if you think about the physics, you've got an air bubble, you got milk on top. When that air bubble inevitably rises, whatever's on top is going to come up too.
Yeah, of course.
So, you know, he's a baby where we have learned over the past 3 months that we need to burp him. And then we keep him upright for a good 20 to 30 minutes, which honestly at night is very hard.
Yeah.
And not everybody is as good about it. So, you know, I'm pretty particular about it, but I find that, for example, if we have a family member, a nanny, my husband feeding, they don't always do as good of a job of keeping him upright.
Right.
And then we put him down. And then if I start to hear that kind of sound, like, you know, that they're gulping, then, you know, I frequently will actually pick him up and just hold him upright as well. Mm-hmm. And that will help kind of with the gravity, just pulling things down.
Yeah.
We have noticed, so he's 3 months old now, and we've noticed that the reflux in the last week has gotten substantially worse, which is normal, usually around 3 to 4 months. But it's still very hard to see your baby that uncomfortable and struggling.
Yeah, I'm sure.
And a lot of parents will say, okay, well, or let's say a lot of family members will start telling mom, oh, what are you eating? Is this something that you're eating? And you end up with these families where the parents are so desperate to make their baby comfortable, which of course I understand, that moms are eliminating things from their diet, or they're switching formula here, every few days, trying to find the one that works. And it's very frustrating.
Yeah.
You can feel very helpless.
Right.
Suffering, and there's like nothing you can do about it.
Do you find that any of that works? Eliminating, I've heard, eliminating dairy, eliminating soy and gluten and, all the typical allergens, yep. Which in and of itself can take a few, weeks for it to completely rid itself out of your system. Is any of that, from what you've seen in your patients as well as with your own kids, does any of that ever actually help with reflux symptoms?
So it's very interesting. Most of the time, no. Mm-hmm. But the symptom of regurgitation of reflux can also be a symptom of a protein intolerance. Now, usually
right.
Protein intolerances will see other symptoms, for example.
Like a milk protein you're talking about, right? Which is not reflux. That's different.
But it's causing a reflux type symptom, right?
Uh-huh.
So it kind of is reflux.
Right.
So milk protein is probably the most common, but you can have other proteins as well, soy, egg. A lot of times we'll see blood in the poop when kids have that symptom, but some kids just have like the reflux type symptom. And
right.
So I will say, if parents are really struggling and they really want to try something, you can try eliminating, for example, milk in mom's diet and you have to do it for a full 2 weeks. To see if that makes a difference.
Right.
Sometimes it does, sometimes it doesn't. But if you look at the algorithm from the National Association of kind of GI physicians, they have like sort of a stepwise algorithm, and that is actually one of their steps. Mm-hmm. So their algorithm is first, so your environmental precautions, so avoiding overfeeding, keeping them upright, things like that. Your second step, and they actually say to thicken feeds, which I'm not a huge fan of. We do it sometimes. If we're at that point, I will often kind of be talking to a GI doctor as well. It's a sort of old school. A lot of old pediatricians will say, just put some rice cereal in that bottle.
Right. And we know that's a choking hazard, right?
It is a choking hazard. And, it can work, but that doesn't necessarily mean it's the best choice. It's obviously only something you would do for someone who is feeding from a bottle. So if you have somebody that's exclusively breastfeeding and wants to continue to breastfeed, it's our job to partly help create a situation where they can fulfill that goal if they're able to want to, right?
Yeah. My mom was told to do that with my sister. Okay, so this was a very long time ago, over 30 years ago now. And my mom still remembers how horrible it was, because I think my sister was less than 3 months old, was not ready. Like her body, her GI tract, wasn't ready to be taking down any amount of rice cereal. And it sounds like my poor sister, as this little baby, just screamed her brains off for an 8-hour period until that rice cereal really began to be digested. So yes, horrible advice. Don't do it.
There are alternative thickeners too.
Mm-hmm.
So, you can buy, there are these commercial thickeners like gel mix and things like that, but I wouldn't be doing that without being under the guidance of a physician who's telling you to do that.
Right.
Just because some of them can have side effects and things like that.
Right.
The next step is when we start thinking about, okay, should we eliminate something from the diet? So this is the way the algorithm kind of progresses. So at that point, we would, if we're thinking, okay, maybe this is a milk protein intolerance and mom wants to continue breastfeeding, you eliminate dairy from mom's diet. So I've seen people temporarily, if they want to switch to something else, and they can continue pumping and freezing the milk and offer a partially digested kind of a protein hydrolysate type formula that is designed for milk protein intolerance or for general protein intolerance, and they can switch to that for a few weeks as well. For the babies for whom this is the problem, that can make a huge difference. It can be like night and day.
Yeah. So for the babies that are formula fed, and let's say they do have a milk protein allergy, intolerance, whatever it is, and they switch to a dairy-free formula, how long of a period does it take before, if that's the problem, would the parent begin to see an improvement?
If this is the case, we say, it can be up to 2 weeks. Usually within like 5 days, you can kind of see the difference, though, honestly.
Right. And then with a breastfeeding mom, it's going to take a little bit longer because, everything needs to exit her body, right? So that takes a little bit longer. But with a formula fed baby, you're saying within a few days, you can begin to see improvement if that's the problem.
Yeah, you may not see the maximum difference until it's been that 2-week period, but you can often see some difference. The trouble is a lot of these hydrolysate formula options are quite expensive. They're more expensive than, standard commercial formula.
Yeah, they can be like $60, $70 a can, something like that.
If your pediatrician writes a letter, I have had insurance companies cover it.
No way.
So that's something I don't think very many people know. But if your child really has like a diagnosed milk protein intolerance and your pediatrician writes a note, sometimes it works.
That's really good to know. I mean, I'm Canadian and I'm in Toronto, and I know that we obviously have a completely different healthcare system than you guys do. But if it's considered, like, do you need a prescription for that sort of thing? Because if it's a prescription, then depending on, you could have, it wouldn't be covered, it wouldn't be free necessarily, but if you have like an extended healthcare plan through work, then you might be able to get that covered. So that's good to know, because otherwise those bills can add up very, very quickly, especially if your baby's a big eater and is going through, one of those cans in less than a week.
Actually, the other thing that people don't know is pediatricians often have samples of these things. And I remember we would have all these samples and people wouldn't give them out and they would expire. So, if your child, and this is true of any kind of formula, if your child's on formula and you're going to like your regular pediatrician visit, ask if they have samples. There's no shame in that. It's better to use it up than to let it expire.
Yeah. No, 100%. That's a really, really good call. Okay. So let's say, all right, you suspect baby has reflux, you have tried offering that baby, smaller feeds. So by the way, so for the formula fed babies, I think it's just important. I want to just get this out here because there are some books out there that talk about feeding a bottle fed baby every 4 hours throughout the day, which entails giving that baby a very big bottle so that they can last a full 4 hours. That's not going to fly if you have reflux. Don't try this at home, kids. It's not going to go well. So that might be great advice for a non-reflux baby. But if you suspect that baby has reflux, feed every 3 hours or so. Don't try stretching them to that 4 hour mark, because then they're going to be so hungry, eat way more than they can handle. And then they're going to be extremely uncomfortable as a result. So you offer them smaller, more frequent feeds. You're holding them upright after, they eat. And, you're trying to eliminate any, possible allergens, and it's still not in control, right? Yeah. So where does medication fit into the picture of treating the reflux?
So we used to have even when I started, so I've been practicing for about a little over 10 years. And when I first started practicing, our threshold to start medications was actually very low. We would be like, let's just try and see what happens. And what we have found is that those medications are not proven to make as much of a difference as we would think. And a lot of times, by the time you get the approval and you start the medication, time is passing and your baby's getting better anyway. Mm-hmm. We'd be committing these babies to weeks to sometimes even months of being on these medications. And it would be something that was probably going to get better on its own anyway.
Yeah.
So if you've tried all of this, your baby is still struggling to gain weight, is still super uncomfortable. Usually this is the point at which I will refer to a pediatric gastroenterologist to kind of get some advice and some monitoring. Now, in this area, it can be hard to get in with somebody for a few weeks. So it can be like 3, 4, 5 weeks to get in with a gastroenterologist. So if you're waiting for the appointment, and I'm certain that this child probably has reflux, then I will sometimes start them on a medication, like an acid suppressing medication.
Right.
I don't like to do it for longer than 4 to 8 weeks, which is consistent with the GI guidelines. And so, what I do is I start it, and at 4 weeks, we sort of reevaluate the situation and see kind of, okay, like, are things getting better? Can we do a trial off of the medication? Sometimes kids need up to 8 weeks, but we really don't want them to be on it longer than that. We want to be doing all the other things. I think the other thing you were just saying about the frequency of feeds and stuff, it's hard, I think, as a new parent to hear that advice and then to read about feeding your baby every 4 hours, and then also to hear, okay, you need to feed your baby on demand, right?
Right. Yes.
It's so confusing.
Yes.
And I think that some of this is just going to be getting to know your baby. Some babies can stretch out, without 4 or 5 hours, like once in a 24-hour period overnight or something like that. And when they feed, they still might do okay. But then what you find is when they're more active throughout the day, that they're struggling a little more with feed. So what I'm finding with my 3-month-old now is like, he's moving around, right? He's kicking, he's squirming, he's rolling, and all those things are compressing the stomach. So if he starts doing that stuff right after a feed, I'm going to see more spitting up and often more discomfort.
Yeah.
But for babies who are naturally struggling even at night or not necessarily extending their period between feeds, then smaller, more frequent feeds is the right advice. It's just the baby hasn't read the book.
Right. Right. No, 100%. I'll tell you how I kind of look at how to rectify the, feed your baby every X number of hours versus feed your baby on demand. Right. Yeah. So this is how I see it. So the whole idea behind feeding a baby on demand is you feed the baby when they're hungry, right? Like no different than like I eat when I'm hungry, you eat when you're hungry. I think we humans should all, for the most part, be eating on demand, right? And so normally when you have a baby, I think the idea behind the 4-hour feeding schedule for a bottle fed baby, not for a breastfed one, that's going to be a recipe for low milk supply and breastfeeding struggles. But I think the idea behind trying to get a baby to go, 4-hour stretches is that if your baby can take down X number of ounces in that feed, then they might not be hungry until that 4-hour mark. Because, what we do want to avoid, reflux or no reflux, is you want to avoid a baby who is snacking all day long, right? So that can also be a problem for many other reasons. And I would imagine it would probably exacerbate reflux as well if they're constantly eating and their body just never has a break, right, to be able to actually digest that food. So the whole idea here is that, yes, you're feeding the baby when they're hungry, not as opposed to allowing them to snack all day long. And then it means that they won't be able to actually take down a proper feed. Now, for a baby with reflux, that proper feed might need to be a little bit smaller than a baby without reflux, because we need to take into account the fact that, their tummy is extra sensitive. So I think that you can still feed a baby on demand more frequently, because it just means that their feeds are going to be shorter or smaller. And then it means they're going to be hungry a little bit earlier than, say, a baby that is eating bigger feeds with longer chunks of time. So what you're not doing is you're not looking at your hungry baby and it's been 3 hours since they last ate and you're going, nope, you need to wait an hour. Like, that's not the idea here. As I said, like, don't try this at home, kids. You don't want to be doing that. But I think the idea is that for a non-reflux baby, if that 8-ounce bottle that they take down first thing in the morning, if they're able to do that, then they likely will be able to last, close to 4 hours. And my son was able to do that. I breastfed him for the first few months and then transitioned him to bottles afterwards. And he was able to get himself down to a 4-hour feeding schedule. But I did look at it as though I was feeding him on demand, because he wasn't hungry by the 3-hour mark.
Yeah. Yeah.
So that's how I think, because I totally get that this can be so unbelievably confusing, and the ideas can sound like they contradict one another. So I'm glad that you brought that up, because I wanted to just sort of take the opportunity to sort of clarify how those pieces of advice do actually come together and don't contradict one another. Does that make sense?
I think the way you're describing it is helpful. And like you said, for a breastfeeding baby, the situation's a little bit different, right? Because you're trying to do everything you can to optimize supply and feeding. And breast milk is usually, there's more to it than just the feeding, right? There's more to it than the volume that they're taking in, and that comfort and things like that, the skin to skin, all of that. For a refluxy baby who is otherwise uncomfortable, some of those other measures are still very important. I mean, that's true for babies, but especially for your baby that's just really not feeling great, to have that in the skin. Now, on the topic of grazing, though, all day, what I have sometimes found with reflux babies is that they have almost a desire to feed more. And that's actually because when they swallow the milk, it's neutralizing and pushing down some of that acid, right? So they might temporarily actually feel better.
Right.
For a little
while. Then do they feel worse afterwards? Is it one of those, is it kind of the equivalent of eating like that big pizza at 10 o'clock at night and you're like, this is so good. And then at 1 a.m. you're like, this is so bad. Like, is it that kind of idea?
What it is. And that's part of why you also kind of want to keep an eye on that and make sure that that's not what's happening.
Yeah.
I'm seeing that a lot with my current baby. He's wanting to do more grazing. And then the other thing is, of course,
and you have to hold him off. You have to tell him, no, I'm telling you, bud, you're going to regret this. You're going to regret this.
And you end up then holding them all day too, because they're your third and you have other children that you have. It is very, very challenging.
Yes.
Because, you're trying to do all the right things. But I think the other thing that's confusing about it then is if you have a baby that's sort of a little on the fussy side to begin with, and they're grazing all day long and then they're fussy, you don't know, is this the time for a feed? Are they tired? Is this just like random fussiness?
Are you tired? Are you hungry? I just fed you an hour ago, but you only, nursed for 3 minutes or fed an ounce and a half. What do I do? I know, I agree. And so I do find that, if you're breastfeeding, to try and limit feeding like less than every 2 hours, because, at least this way, if it's been at least that 2 hour period, you're setting the baby up to be able to take down a bigger feed and then naturally not be hungry for at least another 2 hours. And the same thing would apply to a bottle fed baby. Ballpark like the 3 hour window. And I'm using the word, I want to emphasize, these are babies here, not robots, right? I'm sure you would agree with me on that. And so when I'm saying, 2 to 2.5 hours for breastfed babies and 3 hours to maybe 4 hours for bottle fed babies, this is like, I'm putting like an ish next to it, like 2-ish hours, in other words, it's a baby, not a robot. Don't think of this in like exact, this is a guideline. It's like a loose guideline to kind of guide you, so that if you know that your breastfed baby ate an hour ago and they're fussy right now, chances are they're not hungry again. They might actually be tired, right? That's a really common, misconception that I find, is that people mistake tired signs for hungry signs. And then what ends up happening is they think the baby's hungry again. So they feed the baby again. Baby will take down like half an ounce or nurse for like 2 minutes and then fall asleep because they were actually tired. But then what happens is that little snack that they had before the nap basically ruins their appetite for like the next feed. So it can perpetuate that snacking cycle. So that's why I like giving people these loose guidelines to, try to maneuver their day around, so that they're not setting themselves up for like a grazer, a snacker throughout the day that can, cause those problems.
And then, of course, the other thing in the scenario you're describing is, so even if they just take a half ounce, you're like, okay, I got to keep them upright. So I'm going to hold them for 20 minutes.
Right.
And so I'm not putting them down or creating any kind of like sleep routine or anything else like that. And so you're sort of setting yourself up for more challenges a little bit later.
Yes, 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 yes. It's funny because I know a little while ago you meant, when we were initially talking about keeping baby upright after the feed, a lot of parents will ask me, is my Sleep Bible program going to help their baby with reflux? And then they'll mention in the same context that the baby needs a bottle or needs a breast to fall asleep. And I'll say, 100,000% it's going to help, because you're actually able to kill two birds with one stone here, because part of the solution is going to involve breaking that food sleep association so they can learn how to fall asleep by themselves and connect their sleep cycles and sleep like a champ. You're also going to help your kids' reflux, because now it means that you're able to, by moving that feed earlier on, they're not conking out while eating and then waking up an hour later screaming because they're uncomfortable from not having gotten burped properly and being able to digest that food properly. So it really is like you get to have your cake and eat it too, by addressing, how they're falling asleep and eliminating that pre-bedtime little snack that they fall asleep on.
And we should also talk a little bit about safety with upright and inclined positions, right? So, there's a lot of products that are marketed to help your refluxy baby that provide a way to incline their sleep surface, so their bassinet, their crib, whatever it is, either by putting things underneath the feet or underneath the mattress or underneath the baby.
Yes.
None of those things are safe.
Yeah.
And if you think about, again, the physics of it, like if they're in that inclined position, what they actually do, their chin kind of falls down because they don't have a good amount of like muscle control, and that chin falling down can close off the airway. So if they're reflexing, it can be a setup for a bad situation. So we do not recommend those inclined sleep surfaces. You keep them fully upright and then you put them down flat on a surface that doesn't have anything else in there.
Right. And do you ever have parents that say to you, but if my baby is on his back and he needs to spit up, like, is that going to be dangerous? That, he doesn't know how to roll yet? Do they have to worry about, choking? How do you respond to that question?
So we do have reflexes that are designed to protect us from choking in that situation. There are some babies, especially babies with kind of floppy airways and things, that struggle a little bit more with that. And they're going to have other symptoms, like breathing issues and things that might kind of cue you into that being what's going on. But they should have reflexes designed to protect them from choking if they're refluxing up, to kind of close the airway.
Right. So they can like turn their head to the side, for example, and then it's not really a concern. Okay.
Itself, a cough itself is a way to kind of protect your airway.
Right. No, that makes sense. And I'm curious, have you ever had, I know there are these homeopathic remedies that are, that claim that they help with reflux. I don't know if you have any patients that have ever tried them, what you've seen anecdotally, or if there is any actual clinical data about those interventions.
I get asked about things like probiotics, asked about things like gripe water and gas drops. Those are probably the three most common things that I get asked about. And they're usually something where people are asking about, I have a generically fussy baby and they're gassy and maybe a little refluxy, and can I try these things? There's no data that supports that gripe water or gas drops are helpful. Probiotics are a little bit different. So there's a little bit of data. There's a couple studies that show that crying duration in a colicky baby can be decreased significantly with the use of a certain type of probiotic. But that wouldn't be something that would help with the reflux.
Yeah.
Unfortunately, babies are not so black and white, right? So a lot of times, a baby that has one problem often has another.
Yeah.
I find with my refluxy babies that they're frequently quite gassy as well, because they're just crying a lot and swallowing a lot of air.
Yeah. Right.
Or, they're swallowing air as they feed, because part of their reflux is that they also have like a tongue tie or something else going on. And so unfortunately, these things are not black and white. I have concerns about a lot of those products because they're not well regulated. And because the data is pretty equivocal, I don't tend to recommend them.
Right. So it's probably just a placebo, if that.
Yeah, or maybe, if I have a patient that comes in and says, I use gripe water and I swear by it, it totally helps my child. Well, I'm not going to tell you to stop something that's helping.
Yeah.
And maybe it's true that there's a subset of babies for whom one of those things is helpful, and we're not able to study it well because we don't know how to kind of define the criteria to know like what kind of baby would that be more helpful for.
Right.
These things are hard to study.
Yeah.
Because we don't have a great way to put babies in the reflux bucket without having, say, colic or without having anything else going on.
Yeah. Yeah. No, I think this has been so unbelievably helpful. So to kind of summarize, those of you who have a baby that you suspect might have reflux, you go to your pediatrician, you'll likely be looking at, smaller, slightly more frequent feeds, hold baby upright. And then from there, possibly explore eliminating foods like dairy, for example, which, could be causing an issue. And then after you've explored those options and they haven't really done much, then it might be a matter of going back and experimenting with medication to see if it works. It's interesting because I do have a few friends who swear by their reflux medication that their babies are on. Like they say, like, Eva, I'm telling you, and a lot of clients will tell me that before the medication, baby was miserable as anything. And then the medication was like a godsend. And then what might happen is like a few weeks later, baby will start getting really, really cranky again. And it's just a reflection of the fact that the dose has to be upped for baby gaining weight. So they'll think like, oh my God, is the medication not working? It's like, no, your baby gained 2 pounds. So you need to just, up it. So it does obviously have its place, but it's not what we don't want to immediately start just, medicating something that might be able to get resolved just with, environmental, non-medical interventions.
I think this is what's hard. And this was something I learned as a reflux parent and not as a reflux as a pediatrician. There are things like that work, right? And unfortunately, sometimes when pediatricians are taught about things like this, they are taught in a very black and white way. Oh, never use medication. Like it only works in a tiny subset of babies. I will tell you, for some babies, it is very clear to me clinically that it makes a difference. For my own babies, for the first 2, it made a huge difference.
Yeah.
And then with this one, it didn't.
Yeah.
And the dialogue between the pediatrician and the parent on this needs to be very open, right? So anyone who's thinking about it in a very black and white way, oh, I will never prescribe medication because it never works. Like that's just not the way life is. That's just not the way parenting or babies are. And you need to be able to have that kind of open dialogue because you're absolutely right. Medication does have its place. It maybe gets a little bit of an unfair rap because we're trying to overcorrect for a tendency many years ago to
like over medicate, like to just throw pills at, well, not pills for babies, but you get what I mean. Throw medication for absolutely everything that didn't necessarily need medication. And I feel like a lot of us, as kids growing up, a lot of us even have, those anecdotes like, oh yeah, I had this or I had that. And rather than just treating it with, this or this sort of environmental change, my doctor just gave me medicine that I didn't really need and had these side effects. And so, I think that there is a lot of overcorrecting that's probably doing here, but we don't want to overcorrect too far to the opposite end of the spectrum that your baby ends up being like miserable for months at a time that it could have been, resolved with this medication. So no, I think that I love your approach that it is intrinsically holistic, right? It's not pro medication or anti-medication. Like it looks at all these different interventions as potential tools that you can use to potentially treat whatever it is, whatever, level of reflux your little one might be actually diagnosed with. So thank you.
Parents with reflexy babies. Also, there's I think a lot of those moms have a lot of guilt. I can't get my baby comfortable. And sometimes you see this sort of uptick in postpartum depression and postpartum anxiety. And recognizing that if the right thing for your baby is to stop nursing and to switch to a hypoallergenic formula to kind of help the whole family. I mean, you're right. It is holistic because like part of our approach needs to be making sure that the health of the entire family is optimized.
Yes. Yeah, no, I totally, totally agree. As someone who has, breastfed and bottle fed all three of my kids, like to varying degrees. My oldest, was breastfed for 3 weeks and it just wasn't happening. And I switched her over to formula. She's now 10. I promise you guys, if you look at her, you'll never know.
No,
You'll never know that she was on formula from 3 weeks on.
Your child, right? This will not be the decision that makes or breaks whether your child succeeds.
Yeah. I saw a really funny meme, talking about this one mom's talking about how, her oldest was breastfed for like 3 years and her youngest was breastfed for like 2 weeks. And she was like, and they both still pick their nose and eat their boogers and eat French fries off the floor. You're all gonna get, and I love breastfeeding. I'm talking about someone, and I support tons of breastfeeding families, but I think it is important to recognize big picture, they're all gonna land up in the same spot, picking their nose, eating French fries off the floor, and it's all good. It's all good.
Exactly. You just have to find what works for your baby and for you as a family.
I totally agree. Amazing. Dr. Playforth, where can anyone find you, if they want more of you in their life?
I am at the Pediatrician Mom, and I write about all sorts of parenting things, both from my perspective as a pediatrician and as a parent.
Amazing. Fantastic. So I will link to that in the show notes. Thank you again, Dr. Playforth. Thank you everyone for listening in, and you all have a wonderful day.